Okay, I'd like to thank Dental XP and BioHorizons for providing this opportunity. And today we're going to talk about areas where you have a tight space, areas where a narrow diameter implant would be beneficial in a region of limited spacing. And we're going to talk some about some results from a clinical trial too. First, let's talk about the prevalence of missing teeth or dental agenesis. If you look at probably the best data available is from a meta-analysis which was conducted in North America, Australia, and Europe and combined 24 studies. You see that there is a higher incidence of tooth loss in women than men in general, and it was higher in Australia than Europe and then North America. But overall, this is a fairly common problem. And if we further look at the distribution of the teeth that were lost, and this is looking at 112,000 people in 24 studies, we find that if you exclude the third molars, the most common site is the premolars, but pretty quickly you get to maxillary lateral incisors that become a problem, as well as mandibular incisors. And these are areas where the traditional size of a dental implant may be too large and may be difficult to achieve ideal aesthetics. So in these areas of high aesthetic demand, in these areas of limited space, we have a limited tooth-to-tooth space. And if you think about a maxillary lateral incisor, the average width of that may be 5.5 millimeters, but with a range of 4.5 to 6.7. And post-orthodontics, this space tends to close down, so they tend to be a little bit more narrow. And so with a space that's 4.5 millimeters, a traditional implant that is even a small implant at 3.25 millimeters may limit the amount of space for emergence of a crown and ideal aesthetics. The problem is even worse for mandibular incisors, where the normal width of that crown space, interdental space, is about 4.5 millimeters. So that becomes a great problem. This is illustrated in this slide. If we look at this case of a mandibular anterior region where there's a fairly good amount of room using a 3.25 or 3.5 millimeter implant, the conventional implant leads to the over-contouring of the temporary crown shown here and a poor emergence profile that leads to compromised aesthetics. So an alternative design would be to consider using a 3 millimeter implant if it could be designed with adequate biomechanical strength. If you look at this patient was restored with a 3 millimeter implant, and he's an 80-year-old semi-retired physician who has a moderate amount of recession, has very narrow root anatomy on the adjacent teeth, and has a malocclusion due to rotation and some wear on his teeth. Yet this tooth right here is a 3 millimeter implant. And if we follow this over time, this is a 6-year follow-up of this implant, you can see that this has a nice emergence profile from the tissue, has relatively good aesthetics, and has held up well for him, and it sort of demonstrates the virtue and the need for some areas with a smaller implant. If we look at some classic literature, and we look at Dennis Tarnow's work of implant spacing for soft tissue and bone, that showed that as the implants get closer together, there's a tendency for the interdental bone to be lost and the saucering to occur down to the area of the teeth. While this applied to what was done in 2003, some of the modern designs that we're using today, this bone loss may not occur to the same degree, and so with some of these smaller implants, we may be able to put them closer than 3 millimeters from one another. But still, if we look at other data, this is taken from Dr. Garber's talk, looking at this, and this is sort of flipping the height of the papilla upside down and looking at it. If you look at from the crest of the bone to the tip of the papilla, what you can go ahead and achieve. And if we focus in on the actual tooth to implant sites, we can see that next to a tooth implant you can get about 4.5 millimeters, and people consider the proximal limit how close you can get an implant to a tooth to be 1.5 millimeters. And while that may be true, if we're talking about a 4.5 millimeter site, we're going to have to get implants closer than that than the conventional two-piece implants. And of course, we look at implant to implant. We say that the papilla can only be about 3.5 millimeters high, and the proximal limits are about 3 millimeters apart. But unfortunately, at some points, we need to get implants that are slightly closer together, and that brings in another indication to think about using some smaller implants. So the key is then to maximize the bone and soft tissue outcomes, and that much of our information that we have is based on previous implant engineering designs. And so they had various thread patterns that were present. Some of the collars, and many of them, were machined or polished collars, and there's different, macro and nano topography. And some of the more modern implants may be able to improve upon some of these aspects. This study was based on a 3 millimeter implant, much of this data, that has a minimal profile, and it has lengths that are from 12 to 18 millimeters. And it's interesting that this was an implant that had a one-piece construction at the time. Now, when we first started working with this, we were concerned that whether or not this implant, being one piece, would have enough strength, or would it fracture or bend. And it turns out that because the whole implant is a solid structure that is one piece, that there's very unlikely that anything would bend. So that early worry was not a concern. But that will come up again when we start thinking about making a two-piece 3 millimeter implant. It had minimal surgery that could be flapped or flapless, and it had immediate temporization. So our concern there was that because this is one piece and it's going to be in an aesthetic area, we're going to have to immediately temporize it, and being a narrow implant, would it fail under function? And finally, our concern is, of course, in the anterior area, that aesthetics is going to be an issue, and would the gold color here and be suitable to not transmit too much of a gray shadow through the crowns that were present, and could we place this implant within 1 millimeter or less of the adjacent tooth and go ahead and preserve that interproximal bone. So that's what we set out. So the potential design advantages of this implant were that it had a modified square thread. So the thread pattern itself has sort of loading platforms of square thread that has an improved load transfer. Also, the square thread pattern gives you a greater surface area, which may be advantageous because as you go to a narrower implant, you have less bone-to-implant contact. And we know that there's an improved histological response to these square threads, and this high bone-to-implant contact, and also increased reverse torque values. Also, this implant is made out of a titanium alloy, which is going to go ahead and add to its strength. Now, what you're looking at here is some histological evidence taken, and this is an implant that was removed after 1 year of function in a patient, and you can see that the bone in close apposition all the way around these square threads with almost an 80% bone-to-implant contact, which is kind of striking. The lower figure is histology that has been taken from a dog model, and you can look at that and you can see that in between these threads there's remodeling of the bone in the spaces, and if you will, there's lamellar bone, or almost the formation of Haversian canals, or a mature forming bone. So this gives us the impression that this lamellar bone formation may be advantageous in this implant. Now, looking at the square thread geometry, one thing that can be looked at is how much torque it takes to remove the implant. Now, in this case, we're looking at the difference between having a little trouble picking up the pointing. Difference between conventional V-thread implants. Okay, V-thread implants, reverse buttress implants, and this modified square thread pattern. So looking at very similar implants in size and looking at reverse torque. So here for the conventional V-thread, you have about 15 Newton centimeters to torque this implant out, and this was done in a rabbit model. In a reverse buttress thread, about 15 Newton centimeters, and a much higher reverse torque here. Now, I know we all use implants daily that have these same thread patterns that may make sense, and they all seem to survive fine when we're going ahead and using them. But the difference may be that as we go to a narrow implant, this increased torque and thread pattern may be helpful. Also, if we look at the bone to implant contact, again, we can see that about 65%, 63%, and 74%. Again, this is just an increased surface area. So when you go to a narrower design, these differences in thread patterns may be significant. Okay, so looking at the difference between titanium, why would you not make this out of commercially pure titanium? One of the things is if you look at the tensile strength, that using a titanium alloy greatly increases the strength of the implant. And so as you get to a narrower implant, and in a few minutes we're going to talk about a two-piece 3mm implant, increasing the strength becomes particularly important. And so the alloy has an advantage in that regard also. So the potential advantages of this implant is its one-piece construction, giving it strength using a titanium alloy. It's one piece and there is no micro gap to be concerned with in terms of remodeling of the bone at the crest. It has a minimal profile. It has a gold U abutment, which may be helpful for tissue aesthetics, and it's a single-stage surgical protocol. And patients truly like that because you place the implant in, and the same day they leave with a tooth there and a temporary in place. And so this implant that was used was a implant that comes in 12, 15, and 18 millimeters roughened here, and then it has a transition zone and an 8mm abutment here. Now, there's some potential disadvantages of using a one-piece 3mm implant. First is that it's a single-stage protocol, so if you don't have primary stability of the implant, there's really no way to bury the implant, to let it osseointegrate more fully, and to come back in and work with it. So the one-piece design also limits the flexibility in placement. It needs to be placed at one time exactly where you need it, and there's minimum ability to prosthetically correct for implant placement. So there are no angled abutments. It's straight. You have to prepare it and use it there. It requires immediate temporization, whereas that's an advantage if you're looking at it from the patient. If you simply do the surgical side of implants, that can be somewhat of a disadvantage because you have to either make a temporary or arrange for that to take place. Also, the implants are under immediate functional load, although we try not to put them into functional occlusion. There's a tendency for a patient to forget about it and tend to use them. So is an immediate load of a narrow diameter implant an evidence-based approach? Well, certainly there's data to support the use of immediate loading. We've talked a little bit about the square thread pattern here. Pretty well established that a random blasted surface that's been acid etched is a solid surface for osseointegration. And generally the sites that we're talking about, maxillary lateral incisors, mandibular incisors, are pretty well protected by the occlusion. And so that is an advantage for some of those sites.